I'm Wendy.
I'm Lauren.
Welcome to our presentation.
We're going to talk to you about our condition of interest, which is the physiology and pathophysiology of nausea and vomiting and antiemetic medications.
And the sources that we used were our pathophysiology book, our pharmacology book,
a YouTube video, here's the source information,
and then from the Journal of Clinical Oncology research article. Now let's talk about our learning objectives. First is to understand the physiology and pathophysiology of nausea and vomiting with our lovely drawing. Second, to understand the mechanism of action of antiemetic medications by their class. And third, to understand the use and side effects of those antiemetic medications. And then finally, to take a look at the research clinical guidelines that support the use of antiemetics for treatment. And then now we'll have Wendy talk about this drawing.
Okay. So basically, vomiting is the involuntary forceful expelling of continence from the stomach. It is the vomiting reflex or the emetic reflex. So in the brainstem, which is this little, we have the medulla oblongata, which is this little red dot right here, and that's where our vomiting center is. The vomiting center has muscarinic receptors on the outside, and when these muscarinic receptors are triggered, the vomiting reflex occurs. Inside, so right next to the medulla is the chemoreceptor trigger zone. The chemoreceptor trigger zone has a bunch of different receptors on it. There's the opioid receptors, the 5-HT receptor, the alpha adrenergic receptor, alpha-2 adrenergic receptor, and the dopamine 2 receptor. So when a cytotoxic agent such as chemotherapy is introduced, the chemoreceptor trigger zone is introduced, which then stimulates the vomiting center, stimulating the muscarinic receptors, and vomiting occurs. The CTZ is outside of the blood-brain barrier, which means that it's more permeable to cytotoxic agents such as the chemotherapy. In conditions such as motion sickness, the inner ear or the labyrinth is triggered, which triggers the vestibulocochlear nerve or the cranial nerve 8, which then triggers the vestibular nuclei. The vestibular nuclei contains histamine 1 receptors and muscarinic receptors. Again, when the muscarinic receptors are triggered, the vomiting center is triggered and vomiting occurs. Another trigger area is the cerebrum or the higher brain center. Things such as emotional factors, pain, repulsive smells, and repulsive sights trigger the cerebrum and that receives the sensory information, which stimulates the vomiting center, stimulating the muscarinic receptors, and again, vomiting occurs. In the digestive system, in the lining of the stomach, in the lumen of the stomach, is deep pits and glands that are made of cells. One type of those cells is called enterochromaffin cells. The enterochromaffin cells release serotonin, which then stimulates the 5-HT3 receptors that are located on the vagus, the sensory nerve, or in this case, the vagus nerve, which then stimulates the vomiting center, stimulating the muscarinic receptors and triggering vomiting. So what actually happens in the stomach is that the lower esophageal sphincter relaxes, the diaphragm and abdominal muscles contract, intra-abdominal pressure increases, saliva and peristalsis increases, the epiglottis closes, and vomiting occurs.
Okay, so I'm going to talk about the medications that are used to treat nausea and vomiting. And there are a lot of different classes of medications, and they actually work on different parts of your body, in your brain and your GI tract and everything, to affect their method of action. So the first class of antiemetics are histamine receptor antagonists, and basically what they do is they block histamine receptors in the vestibular nuclei to make their effect. And an example of this is promethazine. These are drugs like Dramamine and Bonine and those kind of things that affect motion sickness. They also really work against morning sickness. The next class of drugs are 5-HT3 receptor antagonists. There are actually a number of serotonin receptor antagonists, but 5-HT3 is the most numerous, and the most common one that we know is ondansetron or Zofran. These are the drugs that end in satron. So there's granisetron, ondansetron, there's a bunch of different ones, and you can see them in the book. They bind to 5-HT receptors in the chemoreceptor trigger zone and block their action, and that's why they're really effective against chemotherapy-induced nausea. Chemotherapy agents that trigger the chemoreceptor zone are the 5-HT3 receptor antagonists block the receptors so they can't bind, and that's how it affects nausea and vomiting. Incidentally, 5-HT3 receptors are also found in the gut, in the GI tract, and that is why they also work for pregnancy-induced nausea as well, and for post-op nausea and vomiting. So it has two benefits, and that's why it's a very common antiemetic drug, because it works both in the chemoreceptor trigger zone and also in the GI tract. The next class of drugs, I should say, are the D2 dopamine 2 receptor antagonists, and they bind to the dopamine receptors to block their action. And there are 3 subtypes, and interestingly, 2 of them are antipsychotic medications. The first one are the true antipsychotics, which are drugs ending in azine. An example of that is prochlorperazine, and then also metoclopramide, and finally droperidol and haloperidol. So all of these drugs that can actually cross the blood-brain barrier are effective antiemetic agents. There's also muscarinic receptor antagonists, and an example of that is hyoscine, and they actually bind to the muscarinic receptors in the vomiting center and take their effect there. Other classes of antiemetics include benzodiazepines like Ativan, cannabinoids like dronabinol, that's Marinol, and then there are neurokinin receptor antagonists, and these are newer drugs. Interestingly enough, propofol, which is anesthesia medication, actually is a 5-HT3 receptor blocker, and it actually, in addition to its anesthetic effects, it actually decreases nausea and vomiting because it blocks 5-HT3 receptors.
Hi, for the third and final part of our presentation, I'll be going over the uses and side effects of the antiemetic classes that we've been talking about. Starting with the H1 or histamine 1 receptor antagonists. Primarily, they are used for vertigo, motion sickness, or morning sickness induced nausea. And the most common side effects are drowsiness and sedation. For the 5-HT3 receptor antagonists, the most common use is for patients undergoing chemotherapy or radiation therapy or post-op induced or nausea and vomiting related to post-op. And the side effects for this class of medications is headache and GI upset. For the dopamine 2 receptor antagonists, primarily we use these for chemoradiation treatment, also in some cases hepatobiliary disorders, or also opioid-induced nausea and vomiting. And the general side effects for this group include fatigue, hypotension, sedation, and the EPE stands for extrapyramidal effects, which includes akathisia, tardive dyskinesia, spasmodic torticollis, and oculogyric crisis. We hope no one ever experiences any of those side effects, but they are definitely listed under the possible risks of taking the medication. Moving on over here, we have our muscarinic receptor antagonists, and these are primarily used for prophylaxis prior to chemotherapy administration or morning sickness to treat that. And these have dry mouth, blurry vision, and drowsiness as the most common side effects. And then the neurokinin receptor antagonists are primarily also used for chemotherapy-induced nausea, vomiting, or post-op nausea and vomiting. And we have common side effects are fatigue, constipation, diarrhea, anorexia, and hiccups, which is different from all the other classes. And then finally, we have a few more listed up here that are used. Corticosteroids for acute nausea, vomiting. They are not recommended for long-term use. If they are, there's adverse effects, which we won't get into for our presentation. And cannabinoids are increasingly popular among chemotherapy patients to help supplement some of the other anti-nausea medications out there. After reviewing all the uses and side effects, it's important to think about using a combination rather than just one specific medication to have the most appropriate and effective treatment. There's a rule of thirds that we learned about, specifically that each anti-emetic that's used helps reduce the nausea and vomiting symptoms by a third. And so if you use a combination, you're more likely to effectively treat the nausea and vomiting for the patient. Also, to look at the specific cause of the nausea, looking at, is it chemo, is it pregnancy, is it, the post-op, what's the specific cause, and then using and choosing the appropriate medication based on what we know of the cause. There's also other factors, and this is the last point, that if you're dehydrated or if you're having pain in addition to the nausea, or if you're having a lot of anxiety, these are all factors that could make the nausea worse or that don't go away when you're on antiemetics, and so it's important to consider these other factors in addition to what we're treating with the antiemetics. And then I put the link up here just as a reference to the research article, and I'm going to talk just a quick minute about it. So this article was published in the Journal of Clinical Oncology, and the American Society of Clinical Oncology used this article to post and publish their guideline update for administration of antiemetics. So in this article, it talks about the expert panel that got together and reviewed the literature and then reviewed the current guidelines and came up with specific updates to these guidelines based on the 41 publications that they reviewed and then posted the results of their findings and the updates specifically for the guidelines in this article, which are now found online, so you can access them using the link. And that concludes our presentation. I hope you learned a lot, and we definitely enjoyed sharing what we learned with you. So, thank you.